this short video, I'll share some thoughts on instruments that can be used to retract the liver during right laparoscopic adrenalectomy. I have no financial or other relationships with any of these companies to disclose. First up, the Nathanson retractor that so many of you are familiar with. I'm not a big fan of this retractor when surgeons use it to simply lift or elevate the right lobe of the liver off the retroperitoneal contents. I don't think that it's nearly as safe as mobilizing the right lobe, which gives excellent access to the adrenal gland and most importantly the vena cava. You can see in this image that there is not enough tension to allow adequate retraction and distraction of the liver and vena cava from the adrenal gland medially, and the surgeon will most likely end up dissecting medially in a suboptimal manner. As I show here in this video from a different case, the right triangular and coronary ligaments are divided. Normally we want to grasp the ligament about 1 centimeter away from the liver to avoid tearing the capsule liver, pull it inferiorly and begin to roll it medially to bring that ligament to us, which will aid in continuing superioromedially to fully mobilize the liver. This is the view we want to achieve so that we can start to identify the adrenal and do our dissection. We'll talk about paddle retractors in a bit. Theoretically, one could use the Nathanson to achieve similar retraction, but I don't usually see that in the videos I find online. However, the Nathanson does not get nearly as much purchase in the liver as the paddle retractor. And on really friable livers in obese patients with steatohepatitis or in those with Cushing's syndrome, the Nathanson and other retractors can lacerate the liver. The paddle retractor allows for broad retraction across a wider area and tends to slide less. Up next, the fan retractor. This is plastic with multiple what I call fingers. There are metal versions of this. I think this is better than the Nathanson retractor, but it still has the issue of the individual pieces causing undue pressure on the liver that can lead to bleeding. In addition, I find it tends to slide around on the liver more than a paddle retractor, and that pressure and distraction at the interface of the liver and vena cava medially is just not as good either. Here's the paddle retractor. In this video clip, the surgeon has already fully deployed it as they maneuver around the liver, and ultimately they get excellent retraction as we saw earlier. I actually prefer to leave it undeployed as I bring it in, get it in position on the liver or the spleen, and then deploy it to the extent I need it. You don't have to have it completely deployed. It allows for directing pressure in smaller areas when necessary. Here's what I mean. This is on the right side. You can see the right kidney. You can see the paddle retractor is only partially deployed. You can also see they still need to complete opening the retroperitoneum for better visualization, and then they can move on to more fully deploy the paddle retractor. This is on the left side. Notice I'm bringing in the paddle retractor as small as possible, which helps me get on the lateral aspect of the spleen. You'll notice I then open the paddle retractor up a bit and roll posteriorly to get into a position where I want to provide more exposure to a particular area of the retroperitoneum, and then I'll open the retractor up more as needed. And you can open and close as needed to work your way around whatever you're doing. When I'm working more superiorly, I tend to have the paddle opened up quite a bit more. When I'm working more inferiorly near the hilum, because of where the port placement is for the paddle retractor, I roll it in and have it less fully deployed to allow me to work in a certain spot. You can also switch instruments around and change the port through which the paddle retractor comes in. Lastly, when we're doing robotic cases, I tend to use a tip-up instrument to retract the liver and spleen. I much prefer the paddle retractor because of the ability to get more purchase against the liver, spleen, and pancreas, which helps provide more space during the medial dissection. I also notice less sliding and need to replace the instrument, and I have more ability to customize the area across which I'm retracting. If you have the personnel who have the ability to utilize the paddle retractor from the bedside while you, the surgeon, are on the robotic console, some will do that. However, I find that the nuances of using the paddle retractor, as well as the safety of being able to place it in the way I would like to, preclude that, and I end up using the tip up. If need be, I go back to the bedside and complete the operation without robotic assistance, although that's rare. Overall, I personally think the paddle retractor is the best retractor out there for adrenalectomy, especially on the right side. On the left side, if you fully mobilize the spleen, sometimes you can complete the operation laparoscopically without a retractor for the spleen and pancreas. Follow me for more tips.